Because many types of cancer are potentially fatal, patients must also deal with end-of-life decisions, such as refusal and withdrawal of life-sustaining treatments. The right to make such decisions has recently been recognized by court decisions and advance directive statutes. Federal law also requires hospitals and other healthcare facilities to discuss advance directives with patients when they're admitted. One type of advance directive is a treatment directive, such as a living will, which enables a patient to specify the type of care he or she would accept or refuse if he or she became incapacitated. Dr. Joanne Lynn is a geriatrician and medical ethicist at George Washington University Medical Center in Washington, D.C.
A patient who comes to me with a living will is a wonderful bonus because it makes it so easy to get started on what moved you to write this, what kinds of things are you worried about. It makes it easy to carry on the conversation.
Another type of advance directive is a proxy appointment, such as a durable power of attorney, which appoints either a family member or close friend to make those decisions along with a physician. Dr. Mark Siegler is an internist and director of clinical medical ethics at the University of Chicago School of Medicine.
I personally, with my patients, find that the durable power of attorney is a somewhat more flexible instrument. It allows the surrogate, the proxy, to work in real time, as I put it, using the real details and real circumstances of the patient's problem, and to make a decision in the present for the patient.
Patients may also combine both forms of advance directives in order to clarify their wishes regarding end-of-life care. For example, a patient may appoint a proxy as well as leave specific instructions regarding future medical care. Even before Carol was diagnosed with cancer, she had a living will drawn up.
I remember you were not too pleased with the way the living will was written and suggested maybe that we might want to consider some alterations, and I had said I wanted to add power of attorney for my brother and sister. I also remember talking about my idea of what quality of life is. And
yes, you brought that up yourself.
What it was that, how I chose to live my life, that I was willing to fight if there was some chance of quality of life, but I didn't want any extraordinary measures taken if it was just to lengthen my life for a few days or a few weeks or drag on something that was painful and terminal.
Unlike Carol, many patients never broach the subject of terminal care with their physicians, leaving it up to the doctor to initiate the discussion. Dr. Siegler feels such discussion should take place long before a medical crisis occurs.
I think these discussions have to start, first of all, when patients are relatively young, and secondly, when patients are relatively healthy. They ought to start in the family situation, ideally, and then they also ought to start in the context of doctor-patient relations.